one of the ways that implementation research motivates the problem that we collectively want to work on is the idea that there are evidence-based interventions that are generally agreed on to be useful and good for health when they're used. Many of these things are very obvious, like medications for maybe malaria or screening for a particular kind of cancer or something like that. Um, and and in most cases, many of these things, which are not always used, are accessible and affordable in most sort of places around the world. One of the recent statistics was that aspirin for primary prophylaxis of stroke and heart attacks, which is really something that is affordable. It's probably less than $1 for a year supply of aspirin in many places in the world, is only used by 10% of people who could benefit from it. So these are evidence-based interventions. There are more and more of them as science in clinical health and medicine progresses, but we're not always good at using them. Um, Now, there is debate in the field of implementation science about what exactly is an evidence-based intervention. Does it have to be something that's studied by, many, many randomized trials and in meta-analyses, or does it have to be supported by professional societies or WHO or other things? I think the nuances of that there may be debate about, but overall, the idea is that there are many interventions that almost everybody agrees are useful for the health of people. Um, so um, implementation science then places the the challenges with use of evidence-based interventions in this idea of strategies. So implementation strategies are ways here, defined by Jeff Curran, but by others as well, sort of methods or approaches to enhance the use, whether it's adoption, implementation, or sustainability of evidence-based interventions or practices. And I think that the notion of strategies is very useful and it's foundational for implementation research because I think that one of the things that implementation research calls attention to is that these things that are done in the course of implementation, which are already being done in public health and healthcare around the world, can and should be thought of as targets of scientific knowledge, right? So um, treatments, if you will, if you would use that word, but they are things that we don't fully understand yet, but which do have, can be understood systematically and structurally and consistently in ways that can help them then be deployed and used in the real world. So, just as many decades ago, people knew, for example, that certain plants may have had certain properties, but they didn't know exactly what it was in the plant, and they didn't know what the dose was or what it was about the plant that produced a clinical effect. Um, but now we do in some ways, similarly in implementation science, we think that there are these things that we do during the course of implementation, whether there are certain kinds of training, certain kinds of data feedback, or other things that are likewise could be understood as treatments for implementation problems, but today we don't have that kind of precise knowledge about what they are and how they work and what context they work in and what their side effects are. But the notion of strategies brings our attention to these things and makes these things in many ways a focus of systematic scientific attention. Okay, so um, for those of you who are exposed a little bit to implementation science, I want to say that my comments here tonight, as well as how I think we should study strategies is based on kind of an analysis of first principles. So we'll discuss what that means, but many of you are aware that there are papers like Enola Proctor's specifying paper where she says strategies, have to have actors, actions, and action targets as an underlying structure of strategies. You may be aware of Byron Powell's paper, Eric, that names through concept mapping several dozen, in fact, 73 or so discrete strategies that are used in implementation. Um, um, if you don't know those references, I think they're worthwhile looking up and being familiar with them. But at the same time, I think what I want to talk about today is um, doesn't uh, take what has been discussed about these things in the field as sort of definitive. In other words, I think in implementation science, we need to continue to explore kind of like the basis of strategies, what kind of strategies are meaningful and how to study them. And even though there is stuff that's published about them that we should be aware of, we don't need to necessarily be um, uh, constrained by them, even though we should make use of them. So I think what I want to talk about today is understanding implementation strategies through a causal and mechanistic lens, and then talk about how I think this would have implications for how we study them. Okay, sorry, this is what I just said. What is a strategy and implementation strategy? Eric, another list, a good place to start. Um, um, but I think I'm going to talk today about how do we think of strategies more generally and propose a structure, a way to think about them. Okay, so one way to conceive of what a strategy is that it's something that has an effect on health. Here, the strategy has an effect on health down here, but only through use of an evidence-based intervention or an intervention. So a strategy has no effect on health directly without the use of an evidence-based intervention. And since use is affected by context, and here I'm using use in the broadest possible way, right? So use meaning use uptake at the systems level, at the organization level, at the healthcare worker level, and at the patient or community level. I'm putting all that complex stuff into one bin. The effects of any particular strategy on use is also influenced by context, which has an effect on use as well. So this is the underlying sort of structure of a strategy that I would propose. You'll notice here that there's no arrow that goes from strategy to the outcome. Because again, what I'm saying is that strategies have effects through use, outcomes on use of an evidence-based intervention. So to be clear, what that means is, like, at least for me, what I'm saying is that if you think about uh, an intervention, or if you want to study whether or not an SMS to a patient helps them adhere to a medication, I think that is a implementation strategy. The SMS does not act on health itself. It's just to remind the person to use something um, that would have an effect on their health. Same thing for an SMS to a provider. You could send an SMS to a provider to remind them to adhere to guidelines. That does not act on health itself, but through provider behavior, prescription, and downstream. So that counts as an implementation strategy in my view. Um, um, but an SMS to a patient, maybe to act on their mental health or to give them encouragement, does not count, or that acts as an intervention in my view, because that has a direct effect on patient health. So all the things that many of the things that we're interested in, whether, generally speaking, site support, coaching, practice facilitation, audit and feedback, community governance of health facilities, um, decision support, um, all these kinds of things that we're talking about, in my view, like fit into this overall all framework, right? From strategy to use, to health. Like meaning that like, the data feedback, coaching, and all these things are these kinds of things that act on intervention use. Okay, so why do I think it's helpful to describe strategies in that way? In a way that, I basically draw a simple causal diagram. Because I think that despite its simplicity, thinking of them that way can help us accommodate the complexity and the contextualization we need to study, what strategies are, how they have effects, and importantly, the generalizability and the adaptivity of their effects. In other words, it helps us clarify what we want to learn from an implementation strategy. And to make this case, I'm going to walk through an example. Some of you on this call, Maggie in particular, I think have heard this example before, but I'm going to walk through a concrete example to try to illustrate, what I mean. But before I go any further, does anybody have any questions? I think because I don't know the network well, I can't be sure that what I'm saying, um, you know, resonates or lands. But if folks have questions or comments before I go into the next section, please let me know.
No questions in the chat until now.
Okay. Okay. All right. Well, let me go on then. So this is a picture of a hypothetical simplified representation of what I think is a strategy that has been in the past and maybe still used in HIV treatment, which is like nurse-led CAGs. Um, Community adherence groups to help distribute ART medications when where people form groups, and then one person in this community group goes to the facility, they pick up medications for the other people, so that only one out of a group of people has to go to the facility, right? So therefore saving lots of potential costs and time to help people stay on medications. So are people familiar with CAGs, the community adherence groups? Um, um, Yeah, I assume maybe that's the case. But let's say that, in a typical maybe scientific question, somebody might ask like, do CAGs have an effect on health outcomes, drug pickup, and then, immunologic function and health? Um, I think that this picture represents kind of that overall effect, right? It's just asking or saying that this CAG formation leads to some downstream clinical outcome. So um, while that might be true and that might be something that somebody would want to study or understand, um, revisiting what a CAG is and how it works to achieve these clinical outcomes by thinking about how it works will help us change what we think we could learn from studying a particular strategy. So here is a representation based on literature of how a CAG would work. And those of you that know this literature would could can maybe relate to this mechanism or set of mechanisms. That's an elaboration on that very simplified um, picture that I showed at the beginning, which is to say that a CAG, uh, when offered to people receiving care, um, if it's acceptable and appropriate and desirable to join, people will join. And then once you join, its effects on on-time medication pickup are probably mediated by four sort of other uh, factors, which form a number of pathways. So the most obvious one is that there are opportunity costs for care that are reduced when people go and join groups, so they don't have to go as much, and their on-time medical clinical pickup would increase. But there's also qualitative data that suggests that if you join, you get social support, which also helps you directly. Social support also acts by helping patient activation and self-efficacy, so people understand their role as helping not only in their own health, but in the health of others, both of which have an effect on on-time pickups. And then there's also the idea that decongesting clinics and reducing provider burnout also helps clinics reduce the burden of being seen, and therefore also has effects on clinical outcomes. So, so thinking of strategies through a kind of mechanistic lens helps us conceptualize in more nuance what they are and how the parts are related in a sort of a chain or a series of pathways to have the effects that they have. So when I when I when I say when I use CAGs as an example here, but I think that the field should be thinking of all of our strategies in this way, right? So, we have Eric and other things that give us a list of strategies, but whether you're working on, whatever you're working on implementing, think of what the strategies you are doing are composed of and how they would work. And in a way, what I think we need to do is to develop these kind of these descriptive theories of our strategies. And using those descriptive sort of theories of our strategies, we can begin to understand them in greater depth and treat them as scientific targets. So how does this help? Well, I think intuitively it probably helps us understand what a CAG is composed of, but more tangibly, it helps us think about three important scientific objectives of understanding a strategy. So one of them is um, the idea of um, using this mechanism to help think through how context would affect the effects of a CAG. So compared to the first diagram, this diagram has lots of mediators. And each of these mediators allows us to think about how context would affect the effect of a CAG. And so by putting opportunity cost for here, we imply that geography and rurality are important contextual factors. By putting clinic and provider burnout here, we imply that human resources for health are important. So in order to generalize, we need to know something about geography, rurality, human resources for health, and elements of context that might be different. But that's one value proposition. And then the other is that we begin to understand how to, I think, adapt the different interventions, the different strategies that we have for interventions. And to be maybe concrete here, um, uh, if this were how CAGs worked, then we might imagine that, in places with high levels of stigma, maybe a stigma reduction adjunct to offering CAGs would be important for CAGs to have their effects. So overall, thinking about our strategies in this kind of mechanistic way has I think benefits for understanding them and thinking about them scientifically. So I think that brings me a little bit to the end of what I'm saying. Yeah, the like thinking of this strategies problem this way anticipates generalizability, helps us deal with adaptability, and advances a science of implementation. So I hope that wasn't too esoteric. I think that diagram may look complex, but it's an opportunity, I feel like, to harness also the complexity that implementers implicitly hold about implementation approaches. Like, people understand that these are complicated things, they have complicated mechanisms, and when we think through them, I think people working with these strategies in the field are oftentimes best positioned to conceive of how they might work and to study them this way. Um, um, so I hope that this representation might, be potentially helpful.
I'm going to share an example of a study that we implemented to further illustrate the difference between an evidence-based intervention and a strategy, as Professor Elvin has been taking us through. Okay, so I'm going to take us through the DEDIM study, which is determining the effectiveness of, determining the effectiveness and outcomes of dispensing messages on adherence and viral suppression among children with an unsuppressed viral load in Uganda. By the time we conducted this study, we were having quite a high number of children with unsuppressed viral load. And as I'll be sharing, one of the things that we wanted to do was to ensure that dispensing messages are available and they are used to give the caregivers information on how to dispense medicine. So this study had two phases. The first was qualitative and then a quantitative study. The background to this study is that in 2019 in Uganda, despite the optimization of children to more efficacious treatment, we noticed that we still had a low viral load suppression at 77%, way below the 95% desired target. And we know that viral suppression among children less than 5 years was much lower. And this was mainly due to poor adherence. And at this time, our children a good number of them were still taking lopinavir, ritonavir pellets, and most of us know the challenges around this formulation. So in this study, we wanted to explore facilitators and barriers to the delivery of dispensing messages at 4 health centers in Uganda, and that was the qualitative study was the first phase. The general objective was to determine the effectiveness and implementation of dispensing messages on adherence and viral load suppression among children living with HIV who had an unsuppressed viral load. And for the specific objectives, we wanted to identify the processes and contextual factors that explain uptake reach and fidelity to delivery of ART. And we also wanted to assess the effectiveness of the dispensing messages on outcomes the two outcomes of interest. And the justification was that to achieve the third 95, there's need for improved adherence to treatment. And for children to adhere to treatment, the caregivers must know how to give the treatment. So our aim was to educate the caregivers at the dispensing points on how to give the treatment. And like I said, at this time, most of our children were taking lopinavir, ritonavir formulations. We had the syrups for the very young ones. We had pellets. We had the tablets for the older children. So we conducted a qualitative study at 4 health facilities. We got approval. We had focus group discussions and also conducted key informant interviews. And some of the facilitators were availability of skilled and knowledgeable health workers, having job aids available for the healthcare providers. And at the Center of Excellence, at one of the facilities, which is a Center of Excellence, they were doing drug demonstrations. So this was found to be very helpful to the caregivers. And the other facilitators were the use of the toll-free telephone, and this was still at the Center of Excellence, and short message service reminders. And at the Center of Excellence, still having individual rooms for counselors and clinicians to counsel the caregivers. For the barriers, the challenges were sharing the counseling and clinical rooms, and this was at the 3 public health facilities. And then dispensing messages were mainly focused on those who are initiating treatment and not necessarily those who are already in care. And one of the caregivers said that to me, the demonstration was done when I had just come here and the child was being initiated on ART. But since then, I have never seen these demonstrations again. The other barrier was negative attitude of some of the health workers, heavy client load, limiting the time spent, the caregivers and the dispensers, lack of mentorship, and negative beliefs, inadequate audiovisual messages. And around that time, we also had the COVID-19 pandemic, which significantly delayed the second phase of the study. So in the second phase of the study, we conducted an implementation effectiveness type 2 study. And this was a pre and post quasi-experimental study, still at the 4 facilities. And you can see that our intervention was the ARV dispensing messages. And we had our implementation strategy, and the outcomes that we are looking at were both effectiveness outcomes, which was viral load suppression, ART adherence, and the implementation outcomes, which were uptake, reach, fidelity. And in fidelity, we're looking at the different measurements, the different aspects that you look at when you're assessing fidelity. So we, as I said, we conducted this study at 4 health centers. And we wanted to have a total of 95 clients for each, the control and intervention arm. And the study population was children living with HIV with an unsuppressed viral load greater than 1,000 copies. And this is how we planned to analyze our data. This is still ongoing, so I'll not be presenting the results. But moving on, in this case, as I've already presented, our evidence-based intervention was the dispensing messages. So this is what we wanted to put out there, and this is just to show you what our dispensing messages looked like. We had the drug name, the formulation, the description of the drug, how it is administered, the drug-to-drug interactions, side effects, and also information for the caregiver on when they should consider coming back to the facility. So this is just an example of what was in the dispensing messages. So for purposes of this presentation and in line with what our topic is today, the dispensing messages was our evidence-based intervention that we wanted to ensure that healthcare providers are implementing. And after the qualitative study, we used the adapted model to refine the intervention, and we went through a series of steps going back and forth to refine our strategies for implementing the intervention. So now on this slide, I share the different strategies that we use to implement the evidence-based intervention, which was the dispensing messages that were given at the dispensing points at the different health facilities. So using the ERIC framework that Professor Elvin talked about earlier, our first strategy was recruit, designate, and train for leadership. So in the DEDIM study, we identified a focal person for the study at each of the health facilities. And this person was responsible for identifying the unsuppressed clients and placing stickers on the files so that when they go to the clinician and to the person that is dispensing the medicine, they are able to quickly notice that this patient is a study patient, they have an unsuppressed viral load, and therefore they focus on ensuring that they are teaching the caregiver how to give the medicine. Our second strategy in this study was to distribute education materials, and here we provided printed copies of the Ministry of Health dispensing messages at the dispensing points, including IEC materials that we had that further helped the dispensers on providing information that they need to give to the caregivers. The other strategy we employed was to remind clinicians, and here we provided standard operating procedures on how to deliver the dispensing messages in a very simple step-by-step process. Our other strategy was to tailor the strategies, and here we integrated dispensing messages at the facilities into the routine and daily health education talks. So we utilized the health education talks and in the clinical rooms as the clinicians were seeing the clients to ensure that they are having opportunities to find out what the challenges are and working with them to demonstrate how they should give the treatment. The other one was to change physical structure. You had in the qualitative study, which was the first phase, that the space or the counseling environment was not very favorable. So here we worked with health facility in charges to identify a space that provided privacy during the demonstration so that the caregivers were free to share their challenges and also to ask questions during the demonstrations. We also used mass media according to the ERIC strategy, and here we provided a telephone number to all study participants to call the study focal person for clarification if they had any challenges. We also used the strategy to intervene with patients or consumers to enhance uptake. And here we generated a list of participants who missed appointments and were able to initiate immediate follow-up of the patients to ensure that they come back for support as needed. Also provide clinical supervision, and here the focal person who was identified for this study conducted daily supervision of healthcare workers at the dispensing points to ensure that they understand the dispensing messages and they are giving the information correctly to the caregivers. We also conducted ongoing training, and through this we conducted monthly didactic sessions on the dispensing messages, and we also provided incentives in form of announcing the healthcare provider who excelled in providing the dispensing messages. So you can see that we employed different strategies, as Prof was explaining earlier. The strategy is what you implement to support you to ensure that you are providing the evidence-based interventions in the setting or to the people that need it. So I would like to end there by acknowledging all the study staff. Thank you very much. And over to you, Laura, to lead us into the Q&A.
My first question is related with the first session, and when you are designing an implementation study and you have your evidence-based intervention and you are developing the protocol, how do you think is the best approach to select which type of strategies you want to implement to really have an impact on your evidence-based intervention? So from a very practical perspective, how you choose the optimal strategies to really improve the implementation?
Is that directed at me, Laura?
Could be both of you, or
Okay.
yeah. But yeah, go ahead then.
Okay, so I think in my view, I think it depends on a number of things. So first, it depends on what you think the problem is with the why an evidence-based intervention is not being used, right? And I think that one of the important aspects of identifying or adapting a strategy is this implementation diagnosis step. A lot of times people who are working in that environment will have a very good idea of what the barriers or problems are, right? It may be that you simply don't have enough staff, you don't have the equipment. But sometimes you have the staff and you have the equipment and it's still not being taken up. So if you have the luxury of doing a little bit more or digging a little deeper, you can undertake a number of kind of research-oriented ways to understand what the problem is, and that could be as simple as sort of interviews. It could be as simple as a survey or other things. But that's a point of departure. So try to develop an understanding of what the barriers are, and then orient strategies towards those. I think there are various ways to kind of tune up your strategy so that it does fit, right? Even if you know what the problem is, sometimes you have to go through a number of steps to identify the strategy that you think is going to work best. And again, this can be done very informally by a group of people who work in that environment, who think about this and say, this is the strategy that we want to use. It can also be done more formally, in a research project or something like that. And in that case, there are methods like, design-based methods, where you bring a group of people together, end users and sort of suppliers, have them work together using things like journey mapping to design it, or intervention mapping, which is a set of steps that you go through. Um, 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 yeah, so there are a number of different methods to do it formally or informally, but at any rate, I think it starts with understanding the nature of the problem and then going from there.
Yeah. Thank you very much. Dr. Eleanor, you want to add something?
Yeah, I'll add something from my program perspective, working from the Ministry of Health. Before I got exposed to implementation science, many times I would sit as technical officers and come up with solutions to the problems that we're seeing in the program without involving some key stakeholders like the recipients of care or the target people for the intervention that we are going to implement. So in addition to what Prof has said, I would add that it's important to also hear the voices of the recipients of care or the target population in which you're going to implement the evidence-based intervention. Thank you.
And I assume also that the resources available, something that could limit also the strategies that you will choose or not, probably. Any other question from the audience? Otherwise, I can still asking. No? So this question is related with what you was mentioned just now, Eleanor, about your double role as a scientist and also as the program officer for the pediatric HIV program in Uganda. So we know that one of the most important things in implementation science is really having an impact on the guidelines, on the public implementation and the policies. So regarding your double role, I know that for you it's easy because you are the one leading the research and the one who is worried about the barriers and trying to tailor the solutions for this. But how is your experience with your colleagues from the Ministry of Health in receiving these results and assuming these implementation science studies and really if they are open to conduct this type of research and assume the results and change and generate a change in the local policies?
Thank you very much, Laura. One of the things that facilitates the uptake of the evidence-based interventions into our policy and guidelines is fostering a strong collaboration between the researchers, the program implementers, and the policymakers. And one of the things that we've done in Uganda is to have most of the people that are leading our technical working groups come from the academia, and they are also researchers. So that has been a very big plus for us, because as the research is being conducted, they are also feeding into the technical working groups, so that by the time the results come out, we know about the study and we are expecting or anticipating the results. So that is something that has worked for us. And very recently, we've also started a research forum at the AIDS control program. And this is going to help us to be able to know about the different researches that are being conducted in the country, and so that we know what is being studied. And we are also going to be using this platform for this very reason of ensuring that we are increasing the uptake of the evidence that is being generated within the country. Thank you.
Yeah, that's wonderful, and it's a great example to other countries also to integrate inside of the own Ministry of Health this research. Thank you very much. I don't see any questions in the channel. Yeah, there's one from Desiree. Thank you for these wonderful presentations. So do we always use DAX to analyze data from implementation research on complex interventions? I guess this question goes for you, Dr. Elvin.
Sorry, I think it broke a little bit for me. Can you say that again?
Yeah, sure. Desiree is asking if should we always use the diagrams, the DAX, to analyze data from implementation research on complex interventions?
I think that is for Prof.
Yeah,
Okay.
the diagrams.
Yeah, so I guess like what I would say is if 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 possible and useful, yes. The reason why I say that is because, I think that we when we solve problems, whether they're problems like in our day-to-day life or problems at the clinic or problems in delivery, or problems in health, when we work as implementers, I think that we think causally, like we think about what affects what. Um, but surprisingly, when we do kind of research, we don't have a lot of tools to help us think clearly causally, right? In fact, we're told not to make causal claims, you know, and things like that. But I think when we use diagrams, it helps us kind of write out what we're thinking in ways that help what we're thinking about become more clear. So just for example, you remember that DAG that I drew, that diagram? It's got 1, 2, 3, 4, 5, 6, maybe 7 nodes in it, right? And it's got 4 paths in it. So if you look at that for 5 minutes or think about it, it's like it's a clear representation of how you think the system works. If you don't have that diagram and you just wanted to describe that using words, it would take a really long time because you would say this affects this, and so it's easy to lose track of how we imagine causally our system to work. And I think that's helpful for us to make that explicit. Because I think we do it anyway, in our minds. I don't know if that helps, but
Totally agree.
These are our panelists. We're going to have a quick panel session where we will have guided questions on the topic that we have just had. So we've already introduced Prof, and it's now my pleasure to introduce Dr. Maggie Nyirenda Nyanga, who is a Malawian consultant pediatrician with interest in infectious diseases, global health, and implementation science. She did her medical training in Malawi. She later studied for MS in public health at London School of Hygiene and a PhD in global health at the University College London. She's also an honorary lecturer at Kamuzu University of Health Sciences in Malawi and an honorary lecturer at King's College London in the UK. She's a pediatric specialty lead for the NIHR South London Research Delivery Network and the lead for implementation science special interest group at the Population Policy Practice Department of the University College London in the UK. Our other panelists, who is not yet introduced, is Laura Fuente Soro. Dr. Laura is an epidemiologist specialized in implementation science with a focus on poverty-related diseases in sub-Saharan Africa. Her extensive experience in the field has been instrumental in addressing HIV and malaria-related challenges, mainly in Mozambique, but also more recently in Uganda and Zimbabwe. For more than 10 years, she has successfully managed multiple projects, collaborating and engaging different stakeholders from the community to the Ministry of Health, and she's currently coordinating the Implementation Science Hub Unit at the Barcelona Institute of Global Health, and is a senior implementation scientist at the hospital, and a researcher at the Manhika Health Center in Mozambique. Her research efforts have primarily centered in implementation science projects aimed at effectively understanding and controlling malaria and HIV epidemics in heavily burdened countries. So welcome. Our third panelist has already been introduced. So we are going to go ahead with the first question that will go to Maggie. We now know the difference between the strategies and evidence-based interventions. What is the role of context in implementing a strategy, and how does context shape the implementation strategies? Over to you, Maggie.
Thank you, Eleanor. So that's really important. So first of all, we'll start with defining context. As you say, what's the role of context? What is context? Context refers to the setting. So in this case, the setting would be the team or the community or the organization where the evidence-based intervention will be implemented. And really the role of this in implementation science, when we're choosing strategies or when we're coming up with implementation plans, is to really understand what happens when the evidence-based intervention is woven together with that team or individuals or setting. So this is really important because it helps us to understand why certain implementation outcomes are going to be achieved or not achieved in a particular setting, and also how. So you showed us a very good example of the dispensing messages. Horse that worked well in Uganda, you might find that a country next to you, that same process may not work well. And it might be that the focal person who was chosen in one of those settings was very enthusiastic. So the climate, the appetite, the culture of the organization could have been very good. But if I did the same in Malawi, where I come from, and if the focal person I choose hasn't got the same appetite and the desire to really implement it as well as we want, we might find that the outcomes will be very different. So understanding all those parts of context when we are thinking of the evidence-based intervention and strategies are important. Even the structural infrastructure, you talked about the room. So if I wanted to do the same, but we didn't have enough rooms, whilst the dispensing message is a very good evidence-based intervention, it might not work if there's no room for privacy and confidentiality. People may not really engage with that intervention. And the other thing I already mentioned about the culture and the appetite, but also resources the patient needs. It might look like it's a very good intervention to us as physicians or clinicians, but if that's not really an important thing to the patient, we might give them the leaflets, we might tell them all this, but they may also not engage. So you find that when we are choosing studies and the frameworks we want to use, the common example is this consolidated framework for implementation research, we always want to look at the different aspects of that context to understand the individuals who are going to be involved. We want to understand the structures, the teams and the resources they have and all these things. So all those will have an impact on the outcomes, and they also have relevance in the way the study is set, the way the study is run. And you notice that each of these settings will be helpful to help us understand and interpret our results. I cannot generalize everything that will come out of the DEDIM study to other parts of the world. This may not work in America or Canada because it might be specific. And also, if I designed a study, depending on the context, I might do a study variation to try and suit the study that I'm designing. Thank you. I'll stop here for now.
Thank you very much, Maggie. And participants, today is Maggie's birthday, so please wish her some happy birthday wishes in the chat. Happy birthday, Maggie. We'll now move on to Professor Elvin. How can we design and test implementation strategies to deliver an evidence-based intervention? Over to you, Prof.
Oh, sorry, was on mute. So just in terms of designing implementation strategy, I think you can, you can have the I think the right metaphor here, you can have the Honda version or the Cadillac version or the I don't know anything about cars, so this is not going well. But the bottom line is, I think you can use things at your disposal, no matter how much resources and time you have to design the strategy, right? And so, for example, what Dr. Magongo just said about starting with talking to people is a very important place to start. So if you're a program manager or a clinic manager or a systems manager, it's easy to start with making sure you know who the end users are and including them in some of your discussions, right? And it could be as simple as a few conversations. It could be a more formal, like a focus group. But this very basic step, I think, oftentimes can easily be kind of overlooked, and I think it's important to bear it in mind. You know, in public health, sometimes we serve up what we think is the best thing we have to offer, and then people don't they don't want it, or they don't want it as much as we thought they would want it, and we are sometimes surprised. I think taking a little bit of a marketing mindset can help us. You know, I think when Starbucks wants to know if they should sell the spiced pumpkin latte, it's not because a bunch of executives in a room decide, hey, we should sell the spiced pumpkin latte. It's because they've done taste tests with probably hundreds and maybe even thousands of customers, and what the customers want, they try to deliver. So I think in terms of strategies, I think that can be helpful. Remember that the first customer, though, of a strategy is oftentimes the healthcare worker, and this is also very important because, you know, no evidence-based intervention. Well, evidence-based interventions usually go through frontline healthcare workers to get to people and populations who need them, and sometimes program managers or researchers forget that frontline healthcare workers are already doing almost everything they can do and are very, very busy. So if your implementation strategy is to ask them to do something new or something more, it might not work, not because they don't want to be helpful, but simply because they can't fit it into their workflow. So things like process mapping, which are very simple ways of understanding workflows, things like maybe a little bit fancier time and motion studies, things like that can help you understand what kinds of new practices could potentially be introduced into a facility. But I think, yeah, there is kind of, I think, a list of methods in my head that are probably, you know, like 8 or 10 things long that help us craft strategies so that they can be responsive to the problem at hand, be based in a rational understanding of why that problem exists, and then you know, accommodate the viewpoint of the different people who are going to be involved in delivering the strategy. Sorry, let me say one more thing about this. I once read this improvement project where they tried to get healthcare workers in HIV clinics. This was many years ago, to do blood pressure measurements, and they tried training and it didn't work. And then they tried where the manager, you know, like did academic detailing, or basically, you know, like yelled at people who didn't do it, and that didn't work very well either. And then finally, they decided to make the lay health workers do it, and that worked. And I think that, like, that is in some ways like a solution, but in some ways, you know, I think it's a product of not knowing which healthcare workers have the space and capacity to do what. It's possible that you can get lay healthcare workers to do the blood pressures, but after they do the blood pressures and the data entry and the screening for depression and this, the next time you ask them to do something else, they may not be able to because they've already, you know, taken up so many things. So let me just, yeah, stop there. I think I've probably gone a little too long. My colleagues will have insightful additions.
Great. Thank you very much, Prof, for those great insights. And we'll now move on to you, Laura. Please share an example of how you implemented an evidence-based intervention, the strategies you used to deliver the intervention, and the implementation outcomes you measured. Over to you, Laura.
Thank you. So I choose one example that we are conducting now, and that Dr. Eleanor and I, we are involved. Penta is also is the partner of the study, and it's the Thrive study, which is a big consortium led by Chai and by Africa, which is a community organization, and by Penta, by us. So the evidence-based intervention that we are going to study is the Stop-AIDS package of care. That I don't know if all of you are familiar with that, but it's a package of care that was launched in 2020, and that basically seek for screening, treatment, optimizing, and preventing. So this is a package of care that we know that works because basically it's testing, treating, and improving the care of the children and adolescents living with HIV, but very like standardized. So it's a new guideline. It's a new recommendation that all of the countries should implement in a programmatic way. Although we know that is a complex package of care that implies a lot of different steps. So basically, the objective of the operational research inside of this Thrive study is to evaluate and to optimize its implementation in different countries. So the idea of this package of care is that should be implemented at all levels of care. So that implies also difference in its implementation.
I think we've lost Laura.
You me?
Yes, we lost her. Oh, there she is.
You lost me?
Yeah, for a
We
second.
lost you
Oh, no.
for a bit. Please go ahead.
Where I get lost?
Just the last few seconds.
Okay. So
Yeah.
as I was saying, the idea is that this package of care should be implemented at all levels of care and along the continuum of care of those children and adolescents living with advanced HIV disease. So basically, what we want is to understand how the implementation is being conducted so far until now, and what are the main gaps in its implementation, and also to address tailored interventions to really optimize its implementation based on the data that we have and based on the current situation of its implementation. So we are going to conduct this in Mozambique, Uganda, and Zimbabwe, this implementation research study. And we are going to include also children that are in different steps of their life. So we are going to include children who are hospitalized, so evaluate the implementation of the stoppage package in the wards of the big hospitals. Also in children who are doing their routine follow-up in general hospitals, but they are outpatients, so they are not hospitalized, and also in a rural district in primary health unit in Zimbabwe. So basically, to do this project, we are going to use 4 different strategies. So the first one is really to use the data and to create a culture of data to action. So the data is there, everyone is collecting the data, but the reality is that we don't use that data normally to really tailor the intervention and to really optimize the implementation in a very local basis. So from the hospital or from the health unit that is creating this data, really analyzing that data and prioritizing what are the steps that could be more impact if we modify or if we change something to really improve that that implementation. So this is the first strategy. The second one will be to really understand the training gaps that the healthcare workers that are in the front line and that are the ones who are implementing in the real world, as you were saying, Dr. Elvin, the ones that are really the end users of these interventions. So understand what are the gaps in training that they had and tailor specific trainings in order to overcome these gaps. So really create online trainings, face-to-face training, but very focused on the gaps that we identify with them. So the third strategy is a quality improvement approach that will be conducted in different versions or different methodologies, but basically using that data that we are using and creating in this data to action approach, and using that data in a quality improvement approach through different workshops, including the community, including the community health workers, for example, and including also the local managers and the healthcare workers from the front line to really ensure that they are the ones designing the strategies that they want to implement to improve first of all, to understand what's happening in their health facilities, and then to design the strategies that they want to really implement to improve and to generate an improvement in their health facilities. And finally, also the involvement of international governance boards. So we create a pediatric expert advisory group that has a representative from each of the ministries of health of all of the countries involved in the study. Also, a specific pediatrician working in the country and in the technical working group. So to really share the learnings from the different countries and ensure that we are aligned, that the results that we found at country level and at the health facility level or hospital level are shared with other ones and are aligned with the guidelines, with the national and with the international guidelines. And basically the outcomes that we are going to measure, we are going to do a mixed methods approach in all of the 3 countries to really get the feedback from the health facility, from the caregivers, from the families, and ensure that with all of those perspectives, we can really answer implementation outcomes such as acceptability, adoption of this stoppage package, appropriateness to understand if really the health units are prepared for conducting this type of complex package of care, and also the fidelity of the implementation. And over.